Oh, wow, they took good notes. But now it's frozen up again. So now you get audio and no picture. Okay, well, at least we can kind of see. Do you see the red here? That does not appear in the lexicon online. It's all the same, and why they didn't put it in red, I don't know. So when you look up a drug in lexicon, it will have the same information, it just doesn't appear in red. So the nice thing in the book, when it's in red, that's specific to us for our local and our dental. So that's directly underneath your pharmacological categories. So you want to find the pharmacological category, and then you want to look at that in specifically. I don't know why it's frozen up. No, we'll go ahead and, if I can just shut it off and just use Elmo. Yeah. And then I can at least show them on the Elmo. Okay. All right. Now we're live, just not recording. Okay, so let's look up. If you look at your ATC form on the back of your health history, now, I am willing to work with anybody. If any of you are confused about any of this, come see me. Well, you guys are in clinic. But come see me, and I'll be happy to work with you because it's better for you to get this down and understand it now than later on, all right? We have patients, and I'm going to show you a couple health histories, and they're not easy. And we get more and more patients that have difficult health histories. So when you're looking up propranolol, you look at your ATC form, the very far left box tells you have to put what in first? The date. And then the next box is? And what's it say on that box? What all do you have to put in there? Drug name, dosage, how often they take it, and why. And we want all of that. And that means you have to have a conversation with your patient. Some patients don't know how much they take. Some patients don't know why they take them. So what do you think your best avenue is to get all that information from them? Call them up before they come in the clinic, yes? Tell them to do what? Take your lovely bottles out, set them down in front of you, and read them to me over the phone. Yes? Because all the information you need is on the bottle. And thereby, again, you're a healthcare professional. Educate them on. You kind of need to know why you're taking these drugs. We had one patient who came in and they were on ACE inhibitor and they had no hypertension, nothing. They were a diabetic and we had no idea. The doctor just put them on it. So we said to him, you know, you might want to go back and find out why you're on that. They did. They came in the next week, and they're on it as a preventative because with diabetes, kidney becomes a problem. And that totally made sense with the drug they were on because it does help the kidneys. And thereby, we help the patient understand more of why they put you on it. And we understood more, too. Okay? So the best avenue is have them read it directly off the bottle. Then you don't have to come to me and go, they don't know. It kind of starts with this letter. We're not quite sure how we spell it. We don't know why they take it. I'm like, oh, I don't know then. And they might have to be dismissed because we don't know what drugs they're on. All right, and you can't afford 3.5 hours of downtime. So talk to them before they come in, get their bottles out, have them read it, milligrams and why they're on it. And all that needs to be in there. Also ask them the question, who prescribed it? Because 3 bottles may be Dr. D and 4 bottles may be Dr. Z. And then what do you think my next question is going to be to them? Yeah, ask, you know, which doctor is which. Is one general, is one a specialist? And the other one would be, does Dr. D know what Dr. Z gave you? And does Dr. Z know what Dr. D gave you? Why is that important? Exactly, what we just learned, right? Drug interactions, yeah. And if they didn't tell both doctors what they're on, the doctors are working in the dark, too, as far as any drug interactions. And then we get it printed off and say, go talk to Dr. D and Z because here's the drug interaction problems. Yes? All right. There are patients of cardiovascular disease. They're on digoxin and Lasix, and those have big D interactions. We never tell a patient to go back and talk to their physician. Cardiovascular disease, those are common drugs they'll put them on, and their cardiologist knows that. And so what we have to watch is that we're not seeing any adverse reactions from them that day. All right? So there will be times where you will see there's D interactions, but it's not that we're going to talk to them and go talk to their physician. Their physician knows that happens, and that's what they have to be on. All right? So when in doubt, just have a conversation with your faculty, too. Okay? So now we have the next column. What's the next column? Yeah, medical consult or not. When are you going to fill that out, do you think? Well, no, basically after you've looked up all the drugs, because you may not know, do we need med consult or not, till we've looked up the drugs to see are there adverse reactions that are a big concern, are there drug interactions that are a big concern. There's really only one drug that we know every single time they come in we need a med consult. And it's in your clinic manual, and it has to do with bleeding. Does anybody know what drug it is? Warfarin, right. Because warfarin and bleeding can change every day depending on their diet and their stress, along with the dosage of the drug. And we never know unless we have those numbers within a ideally 24-hour period. And we have that information in your clinic manual too, under the risk management, okay? So those patients, again, we need to have it. So you have to schedule their appointment accordingly. We just had one gentleman, he couldn't do it, so he totally understood. He goes, nope, I'm not coming in. And we said, we totally understand that, yeah, because you can't get they have to go to a lab and pay for it to have that done. And most of these patients, if they're fairly well controlled, only go in once a month, maybe at the most every 2 weeks. Well, that doesn't facilitate for the number of appointments that we have. So we totally understood that, this was not the place for him. He needed to go to private practice and get it done quickly. All right, so if you look in your clinic manual under Section 4, Risk Management, there's where you're going to find the majority of the information for your one assignment. We used to call them appendices, but that's all the information pertaining to patients with special issues. And here is your antibiotic. Your blood pressure is here. Your antibiotic is here. And ladies, you do need to start learning the names here. All right, we've got them there. You need to start learning them. You have to know all of this for me at Therapeutics a year from now. So just a heads up. And then here's your warfarin. Here on Section 4, page 8, for your warfarin and the numbers and what you need to work safely with your patients. Here it is for drug interactions with your local anesthetics, local and vasoconstrictor, because you're given 2 drugs. That cartridge contains 2 drugs. Here's for your diabetic patients. And are you going through some of this with them, Ms. Runzer? Okay, all right. And again, anytime I can help anybody, come see me, and I'll be more than happy to discuss any of that with you. So now, what's your next column on your ATC? Yes. So now, we'll go back to our lovely propranolol. Zoom this back in. So the very first thing you're supposed to list in that last column is what? Therapeutic category. Therapeutic category is also known as the pharmacological category. Anybody see what the name of propranolol's pharmacological or therapeutic category is? See how we have lots of names there? You have to write all of those. Okay. Some of your faculty, and most of them will know it by beta-adrenergic blocker non-selective. But you have to write all of these because we don't know what faculty knows it by what name. So you write them all. Those are the drug categories. And then what do you write next? Drug interactions and what else? And what? Adverse reactions. We don't care which one of those you write next. It doesn't matter, but we just need them in that column. But we absolutely have to have first listed the drug category. You have to have the drug category. And we want all the names there. And then you can list whatever you've looked up next, adverse reactions or drug interactions. Either one's fine, but we need them. Okay? Now, is everybody listening? You can write it down. Okay? Is everybody listening? If you write anything after the drug category, that means you can never write no ATC. Okay? Because if there's information after the drug name, then there's altered treatment care. Yes? Does that make sense? Altered treatment care either because of an adverse reaction or a drug interaction, or maybe both, depending on what you found. So the only time you can write after the drug category, no ATC, is when you found absolutely nothing under adverse or drug interactions. Clear? All right. Now, some of you will not really see or understand what it is you're looking at. So if you do the drug lexicon and you want to write the C, the D, and the X, that's totally fine. We don't require that you put in there that it will increase this drug, it will decrease that drug, etc. We just want you to put the drug name. We know there's an interaction. The faculty can figure that out. Now, a year from now, you have to put more because you're learning about the drugs. But for right now, We just need to know as the faculty, oh, yep, okay, there's this drug interaction or this adverse, and we know there's a problem. If we need more information, we can look it up ourselves. Adverse because of the drug they're taking. Interactions because of drugs we may give them, thereby we don't want to give that to them, or drugs that they're currently on. Yeah, remember, you're looking these up, and you're adding in, you have to add in the JCCC meds, because we need to know if we give them something, is that going to present a problem? Here's what happened. The patient was on, I can't remember what drug they were on, and she tends to get thrush, candidiasis. So she asked our dentist to write her a script for an anti-candidiasis drug, and she likes diflucan, which is an antifungal. So she did. And that's why our regimen has now changed because of this. That is not a cheap drug, and thank God she didn't go fill it. As soon as naturally the chart came to me, and I'm like, oh my God, okay, no, she can't be on this. There's a major drug interaction here between the drug she's on and diflucan. So we called her up. Luckily, we got to her before she spent the money on the diflucan and said, no, doctor will have to write you a different script because there's an interaction there. So that's what our protocol is. You got to look up every single drug that we possibly could recommend or prescribe for these patients. And recommend being it doesn't need a prescription. We might recommend ibuprofen, aspirin, etc. Does that make sense? All right? Okay, good. So looking at your lexicomp, you can look up each drug individually, or you can do the drug interactions. If you do the drug interactions, you don't get adverse reactions. You only get drug interactions. Did you all see that? So if you need to know the pharmacological category, let's go back in there. Unless you know how to read these, which most of you won't, you will not know what the pharmacological category is by these drug interactions. If you notice, all it does is give you the name of the drug. It doesn't tell you the drug interaction or the drug category. So you still have to look them up, all right, to get the drug category. And then with that, you have to look them up to see what are the adverse reactions. You can either do that in the computer or you can do it in the book. In the computer, you just look up, if you go back here, you plug in the one drug and you look it up one drug at a time. We've got patients who come in. I'll show you the one we had just last semester. This was sweet. Oh my goodness, I wish our patients were all disorganized. But they're not. I think I brought it. Yep. Oh, I'll switch it over. I'm telling you, ladies, you rarely get this, but it was sweet when he did this. He typed up the whole thing. Medication, diagnosis, interactions, etc., etc. We had pages. We rarely get that. We're lucky if we can get them to put their Bibles in front of them and read it over the phone. Don't be surprised. We have many, many patients who come in, they're on one page of drugs. And that's small. We'll have some with even more. So you got to question them. And many of them will ask, well, why do you need to know? I'm just having my teeth cleaned. So why do you need to know? Because they're going to ask you that. Why do you need to know? I'm just having my teeth cleaned. Anybody? You don't know why you need to know? Take a guess. Pardon me? Correct. And what else? What is the other thing you're looking up besides drug interactions? Let's go back to propranolol. We'll zoom this in. Many times your patients need to be numbed up, yes? So we've got to give them drugs, yes? So why do we need to know what drugs they're on? So we don't cause a problem, yes? And also with dental treatment, some of the drugs they're on may create bleeding, may create candidiasis, may create xerostomia. What do we care about xerostomia? What's that put them at greater risk, do you think? Caries, right? And there's also drugs like warfarin and some others that create more bleeding. We did have one gentleman that had diabetes, wasn't well controlled, was on a high dose of aspirin along with an anticoagulant. He had periodontal disease. It was totally out of control. We had trouble controlling his bleeding when he was in here. Shame on us, we didn't pay attention to all the red flags. And he went to the emergency room that night because he couldn't get his mouth stopped bleeding. Okay? So we're trying to safeguard the patients, yes? So let them know that. Majority of the time, nothing happens. But you don't want it to be that one time that it does, yes? And in a nice way, you can remind them, I'm not really cleaning your teeth. I don't take a mop in there. You clean them every single day when you brush and floss. I'm really removing what? I know Mrs. Runzer's talked to you about this. Do you take a mop and a toothbrush? I mean, if we're cleaning their teeth, why don't we just brush their teeth and send them on their way? Yes? We don't do that, do we? And thereby we need to pay attention to the whole body, yes? This is connected to the rest. And you'll learn more and more, and I know there's commercials on the radio, which is wonderful, talking about, oh, the oral cavity. Some of the disease in there can be related to cardiovascular. It's wonderful. They're finally figuring it out. This is related to the rest. So looking in here, we find this immediately, but then we go to adverse effects. Ideally, ladies, you're going to find most of the adverse effects that we're going to have in the clinic here, but you can always look down here. We had one lady who came in. She was just put on Lodine, which is a prescription anti-inflammatory because she had arthritis. And she just said to us, you got to listen the whole time your patient's talking to you. I've been doing my needlework, and my hands have really been feeling swollen. So we look up her drug, and we're like, okay, 1%, but we didn't find it in the red. We found it below. 1% has swelling at the extremities. So we went back and said, maybe could be, talk to your physician. She did. She came back the next week. They put her on a different one, and it all went down. Okay. One gentleman came in as a regular patient of record. His blood pressure was high. We're like, yeah, he said, I did take my medicine, but I've been having back pain, and they just put me on an anti-inflammatory. So we looked it up. Drug interaction. Many anti-inflammatories will counteract some of the hypertensive agents. So once again, we didn't tell him to stop anything, but he was so good. He got on the phone at me, talked to his physician, went in, put him on a different drug, blood pressure came down. All right? So you become a very good patient advocate when you look this stuff up and try to help the patient. You don't intend to, but it ends up working that way. Clear? Yeah, Joy. No, no. What you're doing is you're listening to your patient, and then you're looking to see, is there anything below there that would be a problem? Majority of what you're going to see is right here. But when I go down here and I see that there is dizziness or nausea, and my patient was just complaining about that, then I might say to them, it might be because of this particular drug. You just peruse this very quickly. The majority of what you all are going to be concerned with is going to be up in here, because they'll have hypotension, or they'll have xerostomia, or dysgeusia, or metallic taste, or tooth pain. Will all be up in here because it's orally related. Make sense? No, you write down what this says they could have, and you listen to your patient if they've just told you that's what they're having. Does that make sense? One patient came in, and I was listening. The student was writing or doing something, I'm not sure. And he had just said, you know, when I go out to eat, I really have to watch. I can't go to the salad bars because they have sulfites in them, and I'm really allergic to that. Well, we can never, ever give them a vasoconstrictor because sulfite is the preservative in that cartridge. The student didn't hear what the patient said. I did, so we got that on there. So luckily, we safeguarded the patient from giving anything with a vasoconstrictor. So you got to listen to when your patients are talking. All right, so then what are we going to look up? Get on that ATC. Well, we did adverse reactions, so what do you have left? Drug interactions. Now, here's where you will have to know your drug list here, or if you're looking them up individually on Lexicomp Online, because otherwise you're not going to know the name of our drugs. So you can print it off, you can write it down, have it on an index card right there with you to know what drugs we might prescribe in the clinic. Clear? Does that make sense? Questions? I'm going to show you one other thing. Yeah, go ahead. Well, you have to write down if they're on a drug and it interacts with the other drug they're on, and you also have to write down anything that we might give them. Mm-hmm. Okay, I'm going to add one more thing in here to show you. Yes. Yes, yes. Mm-hmm. And we want the C's too. We want the C's because you got to monitor that. So some of those C's, we don't give them drugs. I'll expect that next year because you'll be in therapeutics then. Yeah. Mm-hmm. Uh-huh. And it, if you want, you could put the D, the C, and the X, and that'll just help your faculty, and then we'll know. Mm-hmm. We're not making you do that, but if you want to, you sure can. Mm-hmm. Okay, I did want to show you one thing. I just put in the local anesthetic that we use a lot up in the clinic, lidocaine and epinephrine. Those are 2 drugs in that 1 cartridge. So I wanted to show you what you're going to see on this lexicon because you may not be able to comprehend it. Yes? Yeah, when you have your box, which I'm going to borrow yours real quick, okay? I got one right here. Too bad this wasn't working to record. Okay, so you're going to write your drug or your drug category here. Then either one of these, whichever one you're looking at next. We don't care. If you want to write the drug interactions because that's what you're looking at next, or the adverse interactions, but both of those have to be in this box. And then ATC information would be if you want to write, but we really don't require it because we now have the ATC box on the front. So we didn't used to have that on the front. So you don't have to really put on there, set the patient up slowly. You'll put it on the front in the front box. Orthostatic hypotension. And that says to us, when the patient's laying back, we don't immediately set them up. Okay, set them up slowly. By saying orthostatic hypotension, we know that. You don't have to say set them up slowly. We need orthostatic hypotension on there. Does that make sense? Yes. Yes, yes. Yes, it is. Yeah, and here's another example because the drug doesn't cause the dizziness, but they have a low blood pressure. We have several females that their blood pressure is 90 over 60. That's fairly low. So my next question to them is, when you are down and you stand up, do you get dizzy? And when they say yes to me, then that says I'm going to put on the front in that ATC box. They're not taking any drugs. I don't have anything to put on the ATC form. But in the ATC box, because their blood pressure is low, I'm going to put up there, set them up slowly. Does that make sense? And you're going to have in your comment section up here the question on the dizzy, et cetera. You're going to have that comment information up there. But it's not a drug, so it doesn't go down here. It's a health history issue. It goes up here. Oh, okay. All right. I don't know, did that answer your question, Morgan? Did that answer your question? Orthostatic. Here, I'll show you. Was it? Mm-hmm. Mm-hmm. Oh, here. Yeah, does everybody see this one too? Everybody's on birth control. So when you look it up on dental treatment, if we have to use antibiotics, then we have to tell the patient what? use a different use a different contraceptive. So that would be up in your ATC telling doctor, you know, avoid antibiotics or something, and then you'd have to tell the patient too. One dentist in Florida is paying for a kid to the age of 18 because they did it. They didn't tell the patient. Too bad for them. Hope that kid's being raised right. Okay. Does that help on the ATC form? You got an assignment. You've got an assignment to do. All right, let me show you this real quick, and then I'll get out of here so Mr. Runzer can have her stage back here. Okay, lidocaine and epinephrine. There's two drugs there. Do you know which drug causes the interaction? Anybody see that? Where'd it go? Inderal is the antihypertensive drug they're on, and it interacts with lidocaine and epinephrine. But does anybody know which one of these drugs it interacts with? Anybody figure it out by looking at this? And you might be able to. I don't know. Yeah, but which one of these is the alpha-beta agonist? Anybody know which one it is? Pardon me? Yeah, you're right. It's epinephrine. If you're not sure which, go to this, click on it, and then you'll go here, summary beta blockers, which is this, interacts with, there's epinephrine. So it's not interacting with lidocaine, so don't put lidocaine on there. It's epinephrine it's interacting with. That's where it gets tricky. So when in doubt, write the whole thing and your faculty can figure it out. They know. All right? They have it memorized. You have to learn that stuff and keep it memorized forever when you're administering local, which you all get to do in a year. Isn't that exciting? What other questions do you have for me? I got to let her continue on. I could go on all day about this. But you have a lovely assignment, so you get to do that. And you'll do great. But if you have trouble, just let me know. Do you have questions, or I'm closing this down?